Hi, this is the third video in the series of 15 videos that I'm doing for students undertaking a pediatric attachment with us in HHFT. In the first video, I gave some ideas and thoughts about how we might need to approach children differently from adults, thinking about their growth, their development, safeguarding issues, how we might think about the history differently considering the age of the child, how we think about the changes in anatomy and physiology and how this might affect resuscitation. I mentioned the fact that we need to think about the differential diagnosis at different ages and the sorts of conditions that might present in the first few years of life compared with latter years of childhood. And I then talked a bit more about growth and how this assessment of growth is so important and integral to how we think about pediatrics, and the ability to interpret a growth chart is such a core skill for us in pediatrics. In the second video, I asked you to think about the history taking in an under 1-year-old child, and I hope that you have now practiced this skill. I hope that you've thought about the growth and neurodevelopmental assessment in a child under the age of 1, i.e. infancy. Some of the routine things that we have to ask about in terms of pregnancy, labor, delivery, and then neonatal period. How we take a previous medical history in terms of what other doctors or clinicians are involved, but also how we think about the social and family history, the construction of a family tree, and understanding who is important in this child's life is going to be really important. And I hope that you have now practiced this skill. I also asked you to think about some of the other things that we need to think about in early childhood in terms of the differential diagnosis. In other words, we may see congenital problems that were apparent or became apparent soon after birth, but we will also see acquired conditions, some of which might be a new acquired condition, such as a viral infection or meningitis, some of which might be conditions that are genetic but have only become manifest in the first few months of life, such as a neurometabolic problem. In this third video, what we're going to concentrate on now is the assessment of a very unwell child and how we need to have a structured approach to thinking about an unwell child. I'm going to focus on how we think about a 2-year-old child as a way of getting you to think about slightly older children and toddlers and some of the challenges of assessing them. Everything you know about assessing sick human beings is true. But I hope from the first and second videos you understand that your approach to a very sick 2-year-old child is going to be very different from the approach that you would use in somebody who was 22 or 62. Specifically, the history is going to be more challenging. There may be some things that you can ask the child. You might ask them where it hurts and to indicate where it hurts, but they're probably not going to be able to give you a very detailed description of that pain, and you're still going to be heavily reliant on the parents. These are parents who are going to be very stressed, worried, and concerned, and are going to want you to really understand exactly how concerned they are. And your job is to try and disentangle that information in a way that is clinically meaningful to allow you to assess that child thoroughly and put a plan in place. 2-year-olds do not like being examined. And part of your basic clinical assessment is going to be how we assess a 2-year-old who doesn't like being examined. And this is what I'm going to be talking about in a bit more detail. Children also don't like having tests done to them, and they certainly don't like taking medicines. And I expect during your attachment for you to spend some time with us watching how we assess 2-year-olds, how we might do investigations, and how we approach treating them when they often don't want us to be anywhere near us and find it very difficult to allow us to do the things that we need to do sometimes in a hurry when they're very unwell, whether it is a blood test or some oral medication or a nebulizer or an inhaler. I'd like you to think a little bit about the basic clinical assessment then in terms of how we're going to think about a structured approach to our history, how you're going to take that history of the presenting complaint, how you're going to very much focus down on the core important signs and symptoms that you need to be able to get from that child. And I want you to think about some of the questions you're going to have to ask the parents of a very sick child. These might be questions in terms of pain, breathlessness, how the child appears in themselves, how they're interacting and moving and behaving, and understanding how that child is compared with their normal healthy self. There are going to be some things that are just plain silly to ask. A 2-year-old is neurodevelopmentally not really going to be in a position to be talking in full sentences. So if you're thinking about an acutely breathless child, asking if they're talking in full sentence is silly. Therefore, we have to have a way of understanding, well, what child can this child normally do, and how they're comparing with how they normally are, and how does this compare with an otherwise healthy 2-year-old? I want to introduce a concept here that I think is really important in pediatrics. Pediatrics is often about spotting what is not there. Diagnosing jaundice is easy. Somebody looks more yellow than they should do. Diagnosing things that are missing is much harder, whether it's anemia, which might be the absence of pink, and we're going to talk about anemia in a subsequent video. A child who's not moving or talking or interacting the way that they might normally do. The child in whom something is missing is much harder to pick up than the child in whom there is something new or different added. And I really want you to start thinking now, from the moment you go to see a sick 2-year-old, or any child indeed, how am I going to think about what is missing from this picture? What would an otherwise healthy 2-year-old be doing that this child is not doing? This is a critical skill, whether you're thinking about growth and whether we're thinking about how well nourished they are, whether we're thinking about how they move and possible neurodevelopmental problems, whether we're thinking about interaction and how this child interacts with you and their carer, but also what's a normal heart rate for this child and how does their heart rate compare? What's a normal temperature? What's a normal blood pressure? What's a normal respiratory rate? This is information that we don't necessarily need to carry around in our heads. That's why we have normal ranges and charts on our Pews charts. And you need to have a look at a Pews chart today and understand how we have different Pews charts for different ages and why that's important. But we have to have the basic pediatric skill of going into a room and asking ourselves a question: what is missing from this picture? We need to be able to take a history just as we would in any other sick human being, focusing on the history of the presenting complaint and getting a really good understanding of the history in terms of its time sequence and tempo and how it fits in with this child's otherwise healthy or not healthy growth and development. But I'd like to spend the rest of this video really thinking about how we assess the child clinically. There are going to be some things that are like adult medicine, but slightly different. Measuring a heart rate, measuring blood pressure, measuring a temperature, measuring a respiratory rate. These are things that we measure in any potentially sick human being. How we do it in a child will be slightly different, and the ranges will be different, and I need you to observe this. There'll be other things that are challenging, but much the same as in adults. For instance, examining the abdomen in a child. They may not want you poking their tummy. They may not lie down nice and calmly and let you examine their abdomen. And so we have to think of ways of examining the abdomen that are going to be more child-friendly and appropriate. Because if you see a child with abdominal pain and tachycardia, they might have peritonitis, but they might just have a viral illness and a fever and be scared and anxious, and that's the cause of their tachycardia. And so we have to have a way of doing an abdominal examination that is child-focused and allows us to get the information. There are going to be some bits of the pediatric examination that are just fundamentally different. I've already stressed one of them, which is neurodevelopment. But there are other things that I would like you to think about that are different, and skills that we need to have thought about in addition to the normal skills you would have in assessing any human being. There are two things that I would like you to think about for today. One is how you assess the ear, nose, and throat. The assessment of an unwell child is incomplete unless you've documented a thorough ENT assessment or your reasons for not doing it. There are ways of examining children's ears and throat that are going to work, and there are ways that are not going to work, and you need to observe these and practice these. Similarly, when we examine the cardiovascular system in a child and when we examine the respiratory system, there are subtleties that are going to be different, and I'm going to discuss these in a subsequent video. The final thing I'd like you to think about before you re-watch this video and then have a think about how you're going to approach this session is the idea that the clinical method, in other words, the structured clinical approach to examining a child, has to be just as robust and thorough as in an adult. They deserve exactly the same attention as an adult patient. The problem is that it has to be opportunistic. I will sometimes find myself doing an abdominal examination or a respiratory examination or a cardiac examination completely out of sync whilst doing a bit of the review of systems and whilst opportunistically watching how the child moves around the room. And the problem with this is that often you will find you sit down, you write your notes, and you realize that you haven't put it all together or you've completely missed something out. You need to be humble and thorough, and you need to go back and complete your assessment. This assessment has to be thorough, or you need to document why you haven't done it. It is impossible to listen to the chest of a screaming child. Therefore, you cannot document a normal respiratory examination in a child who's crying at you. You can document the fact that the child appeared to have no signs of respiratory distress whilst they were sat comfortably on their mum's lap, and then they started crying when you examined them, but they didn't have increased work of breathing or desaturate. But you can't say that there were no focal signs in a child who was crying, just as you can't exclude a heart murmur or a rigid abdomen in a child who's screaming at you, or say that somebody's neurodevelopment is normal when they're lying there not really wanting to cooperate with you because they're feeling so rubbish. I want you to watch this video again. Have a little think about how you are going to approach a very sick 2-year-old, how you're going to think about the assessment of their physiology, assessing them in a thorough, structured, top to toe way, and how you're going to think about a focused approach to that child that allows you to then go away, talk to your seniors, and put a plan in action.